Thank you for general introductions. I'm Dr. Kuo-Wu from Rhode Island Hospital. Actually, I have been in Rhode Island for 4 years. 20 years ago, Dr. Odd and I actually started the center, started Memorial Hospital 2003, then we moved to Rhode Island Hospital 2005. And my senior partner, Dr. Odd, retired 2020, so I was called back in to take over the director job, and I'm very happy to come back to Rhode Island. After I left Rhode Island in 2007, I actually went to Northwestern in Chicago. I have the opportunity to work with the directors and many lovely colleagues of Alzheimer Association, headquartered in Chicago. So I know quite a bit of them. And then I moved to Texas as an endowment professor, trying to help the Alzheimer care in Western Texas, Lubbock, Texas, Texas Tech, actually. So I kind of experienced in the rural area of the countries, and then I moved to California, UC Irvine for 5 years and run a specialty clinic before I come back here. So today my assignment is actually review a different type of dementia, and this is my objectives. Actually, a lot of people ask questions, and I think a little bit of history will help, and particularly the difference between aging and Alzheimer's disease, and then how to differentiate and also make the diagnosis of dementia is always puzzling in a way. And there's a new term called mild cognitive impairment. It's a diagnostic entities that have been created and emphasized and researched in the past 20 years. And then with the new technologies of the diagnostic tools, particularly PET scan and spinal fluid and blood fluid, it actually expanded our diagnosis of the Alzheimer's disease into a very, very early stage, even to asymptomatic stage. And then in the differential diagnosis, when we take care of patients and learning through the autopsy in the NIH-funded Alzheimer's Center, we found out our diagnostic capacity is not perfect, and we learned there are other neurodegenerative disorders and neurological condition can mimic or mix with the Alzheimer's disease, and these are the following conditions like a vascular dementia, Parkinson's dementia, Lewy body dementias, and the frontotemporal dementia. So I would kind of start with a little bit historical review, and this is how I learned them. There's always a question about what is normal aging and what is senile. The senile is a term has been used in a more negative way, but actually there's a lot of misunderstanding of that. And Alzheimer's disease was described by Dr. Alzheimer's more than 100 years ago, since 1906 to 1911, and it was reported based on a case. She had the disorders in her 50s. So in early days before World War II, people labeled so-called pre-senile dementia as Alzheimer's disease because that's based on the case Dr. Alzheimer report. But then what you see in the nursing home for people, older folks, and to their age range from 60 to 70s, then you call it senile dementia. Those are the terms have been used very commonly in 60s. And based on autopsy, what we learned in 60s and 70s, we found that if you look at a brain scan, an examination, a brain examination by pathologists, actually what you found the change in brain, they are the same. So that's why after 70s, we abandoned use to differentiate pre-senile dementia, senile dementia, because look at the pathology finding is actually what the Dr. Alzheimer described. That's actually can be seen in younger patients or older patients. So that's why we go straightforward to diagnose Alzheimer's disease. And with the recent research, particular 20 years, we also studied a group of a senior. They actually live so-called older than 85, all the way to 100. and you found that there are a lot of senior, they are very highly functioning. They don't show the decline as you expect from aging. So my colleague in Chicago, Northwestern, they call them super ager. Or the other people, they call them healthy aging, because based on their cognitive assessment, their ability on the score is very equivalent to people in 50s. And they're still very active. So we try to learn from them. And there is a large study in Irvine, UC Irvine, where I used to work, and followed about 300 people older in the 90s, called 90+ study. And we learn from them how they kind of live a very active life, and they receive the testing every year, and then also donate a brain for us to study them and review their lifestyle, nutrition, and so we learn a lot from them. So there is a big spectrum from aging to dementia. I shift the topic because Alzheimer's is often emphasized in memory. People come to my clinics and actually often say, my memory is not as good as before. In fact, through the research on memory function, normal memory functions, if you read this recent book by Dr. Daniel Schechter, he is actually at Harvard University research on the normal function of age, memory and the agings, and particular memory functions. He has a book called The 7 Sins of Memory, which means our memory is not perfect. There are 7 situations that will make you forgetful. If you are not actually pay attention to these will make you trip in your memory. So you can, the book just have revised last year to have 20 years of revisions, and very interesting examples and how to avoid these weakness. And the aging studies actually found that when we're getting older, these are very common phenomena, difficult to retrieve the words and thinking slower, because when we get older and have more experience, you take time to think. The accuracy is more important than speed. So that's really is the thoroughness and the wisdom, so make you think twice about what you want to say. That's why we honor the members of Supreme Court judge. They are, very smart and thoroughly considered for decisions. When we get older, what's most important is to crystallize knowledge and the wisdom. That's actually what we gain from the years of learnings and real-world experience. And storage of information is more crystallized in a more a form of like a poem, so that you can just say some words and you kind of summarize a lot of details. So that's really the outstanding feature of aging about our wisdom. So the next one I really want to talk about, a lot of people never had a clear-cut definition of what the dementia means. And this is actually, I spent 5 years in PhD programs. My first question posed by my mentor at Boston University is, do you know what's the dementia definitions? It took me about 3 months to search all the literatures and find out origin of this term. So origin of term in Latin is actually very simple. It actually means that you're out of mind, but the mind means that you have learned. It's not unlearned mind. It's actually throughout your educations and formal education right now from K to 12, you learn skills. And that learned skill reached a peak around 20s or 30s, depends on what skill you try to learn. And dementia means that your skill, the acquired cognitive skill, impaired. And there's different degree of impairment. And if you impair to a degree severe enough, you cannot do your job. And that's called dementia. That's actually a very general ideas and descriptive term to really describe the situation and conditions. And this term is actually used as a descriptive diagnostic term, as a starting point to recognize the conditions. And they unfortunately have been used in society in a very negative way, so that's become a term a lot of people doesn't like it. And recent DSM-5 changed the terminology into so-called major neurocognitive disorder, try to replace the term of dementia. But you're going to create another term, become negative use. I'm not saying it's going to make a positive impact. But this particular term have been used initially to describe a formal diagnosis for schizophrenia, what we learn now. And turned out, used to be incurable conditions, but then we found that infections, conditions, syphilis, actually can be a form of the dementia, causing dementia condition, and it's treatable after penicillin was discovered. So that really created hope of that this terminology is diagnosed condition. If you look into the causes, there will be some form of the condition they can actually treat it. And this catch bring to Mr. Reagan. He's actually contribute greatly to Alzheimer's world. In 90s, when he announced that he has Alzheimer's, that's really opened the door that we can talk about disease. Before that, I remember when I was in training in Boston, been told that you cannot say Alzheimer's disease when the patient is alive, because that is considered as a pathological diagnosis. You can only make diagnosis when the patient die and donate a brain, and pathologists tell you. But because this really delayed the research, particularly for treatment. So that's why we kind of really come out with a set of diagnostic criteria. And if you read Mr. Reagan's letter that time, I read it several times, it's amazing that when he was actually in the disease in an early stage, his handwritings, you can actually read the books. Nancy Reagan actually published a book about his original handwriting of his letter. It's amazing. That's actually his own way to form the words and with a very beautiful writing. I always thought that was somebody write for him. But then actually I look at the publications. Nancy Reagan actually published in a book about his original writing on the yellow pad paper. It was actually his own writing. So this is actually tell you that even in a mild stage of Alzheimer's disease, with a very intelligent person, they can actually form the words and express very nicely. So that's actually kind of should be able to take a fear from what the Alzheimer's disease affect to a person. And Dr. Alzheimer, this is his pictures, and then this is the picture of his patient he reported, a woman in 50s, actually in a long-term care facility. Dr. Alzheimer's visit her every day, just write down what her behavior and change. Eventually, her brain was examined by Dr. Alzheimer, and he described this change in the drawing the picture at that time. But it actually took about more than 50 years to describing what it actually means in terms of molecular levels with the modern technology, electron microscope and biochemistries. But in the real world, what does it actually become a very important condition we need to pay attention in the societies? Actually, it's Dr. Robert Katzman. He was my mentor's mentor. I have fortunately studied under him when he was in his retirement at UC San Diego. Dr. Katzman was the chairman of the neurology at Albert Einstein Medical School in New York at that time. And he found that there are nursing home patients, they actually had cognitive changes, dementia, and he found their diagnosis with the autopsy, working with another legendary neuropathologist, also named Robert Terry. He was the one that actually discovered what the tango means in the electron microscope. And two Bobs worked together from New York and moved to San Diego. And he actually, Dr. Katzman was the one actually in the 70s told everybody that when the people getting older and healthier, Alzheimer's disease will become prevalent and malignant conditions. And he was one actually single-handed as NIA to put the money of research in Alzheimer's disease. when the NIA started with a minimum funding, about $2 million. They really don't know what to do for their topic. NIA was the only agency actually funded research for Alzheimer's disease at that time. And Dr. Katzman was the one actually pushing to expand the programs and open up NIA-funded Alzheimer's center around the countries. And start with 5 of them. Dr. Katzman was the director of 2 and moved to the West Coast in San Diego. So, and his first contribution is that the Alzheimer's disease really linked with age. When the aging become older, then you will see more of these. And this is what we see now. And this was from his original paper with different cohort. He found the same phenomena. And this is actually you'll see around the world. So if you have a healthy societies and people increase their lifespan, and you will see Alzheimer's become more obvious and become a healthcare a test you need to provide. And this is what we have in the United States. With the effort of Dr. Katzman and NIA, so in 80s, this is what we started to form a so-called clinical diagnosis of Alzheimer's disease. And this is really not too long ago, less than 50 years ago. And so the history of diagnosed Alzheimer's disease used this set of clinical diagnoses. It was established in 1984. And then we can say, okay, I think the patient has Alzheimer's disease as a clinical diagnosis. So we can move on to say we'll study the diagnostic tool and most important study for treatment and care. And that's actually the breakthrough in our field. But this is actually, a lot of people doesn't know it. So a lot of people, when they come to my clinic, told me their mom and dad have been diagnosed with dementia. I usually ask them, what year? Because if you're before this 84, very rarely they use Alzheimer's disease. They just tell you dementia. But if you after 80s to 90, people are more likely to say this is Alzheimer's disease. And Alzheimer's Center was established by NIA is help the clinician confirming this diagnosis. So if we have a collections of patients and they're willing to allow us to look at the brain to confirm our clinical diagnosis, with a set of diagnostic criteria, we're actually accurate about 85%. And this set of criteria been studied again about from 2000 at that time. We still have 75% diagnostic criteria. So it's not perfect, but it's good enough for manage most of patients because the brain is just, you cannot approach like the kidney and heart and liver. So we have making a certain degree of educated guess, but with a more knowledgeable about the clinical features and MRI and how they change, we're more confident say this is Alzheimer's disease. Accuracy is at least about 85%, and we can actually start with the treatment. And this is the first treatment has been studied in the 90s. If we study them, and this is actually how to reach the diagnosis, in a clinical setting, this is actually the most important slide when I teach the medical students and residents and fellows. This is the slide I actually emphasize every time, is the principles of diagnosed dementia. You have to document these components. One is they do have impairment of cognitive functions by objective evidence and also subjective report. And that particular impairment does affect their certain tests they used to be very good at or specialized, or that's what their job. And that's where you have to conclude that this is really called dementia based on what I just talked about before. And that's what the note need to be stated that way. So when I read the people's note, the residents' note, and my note, this is supposed to what is be written. Otherwise, you cannot establish a diagnosis. And this is the first step. You go on to diagnose what's the cause of dementia. A lot of people actually confuse dementia and Alzheimer's disease, often use interchangeable, but it's actually the difference is that the dementia is a clinical condition. You have to make diagnosis first, and you're looking for causes. And Alzheimer's disease, one of the causes you want to rule in. And before you rule in Alzheimer's disease, the clinician usually have to check on a general things, a general condition. That's why the primary care doctor, they are very good at this. They actually check for blood tests, check for general chemistries, and make sure there's no cancer, there's no nutritional deficiency, there's no thyroid disease, and a lot of these medical conditions can mimic and create the cognitive change mimicking early stage of dementia. So these are all treatable conditions, and these are the first step to do when the primary care doctor refer patient to our specialty clinics, and then we'll use the more certificate test if we are not sure about the cause of Alzheimer's disease, because Alzheimer's disease will present a very specific feature, and that will help us make diagnosis. Now, the next step is really to see, I just talked about the so-called approach, is really to looking for what are the secondary causes, like old days of syphilis. Right now it's much less now. Recently, we'll make sure there's no thyroid problem or B12 deficiency, there's no head injuries or traumas or stroke. And these are so-called secondary insult to the brain. And then the other one is that if the stroke happened multiple times and have impact to the brain, the stroke by itself can cause cognitive impairment. This cognitive impairment from the stroke, we usually call vascular dementia historically. But they also sometimes mimic in Alzheimer's disease. And once you go through these thinking process, then you come down to so-called primary cause. The primary cause means these are the conditions it changed by itself in the brain cells. Particularly, we talk about neurons. That was the principal cell in the brain carry out the brain function. And the change of these disorders are based on their molecular components inside the cell, and they change. We still don't know the actual cause, but we know several of them, it's a main player of causing such as Alzheimer's disease. And Alzheimer's disease is the most common and most studied conditions. And the other condition like frontotemporal dementia, Parkinson's disease, these are all combined together. We call it neurodegenerative disorder because the change is really start from the cell in the brain. So that's actually become more difficult area to diagnose them. And the problem is really is accuracy of diagnosis. We are based on the clinical symptoms and what we see. We cannot diagnose them based on the microscope. And once you look at microscope, it means the patient already died. We don't want to wait until then. So that's why we create a lot of tools to try to diagnose them. The other important step is that even you diagnose Alzheimer's disease in terms of treatment, there's different stages. Actually, that was how we designed to apply the proper treatment. And this is the area a lot of people are not paying attention to, is that there is a so-called mild stage of dementia due to Alzheimer's disease, and there's a so-called moderate stage of dementia, and there's a severe stage or go into advanced stage. And I want to remind you, we try to avoid so-called terminal stage dementia because Alzheimer's disease is not like cancer. Cancer, they call it terminal because they are life-threatening and die from the cancer. Alzheimer's disease, in fact, does not directly cause the death. So we usually call it advanced stage after severe. We don't use terminal stage of dementia. And the other scale using so-called dementia rating scale, they use the different numbers, 0, 0.5, 1, 2, 3. It's the same idea. And there you will see the internet, there's 7 stages, there are 4 stages, there are 5 different stages. We don't use that often, but in research, some people apply that. This is the one we actually use that in the actual treatment because the medicine approved by FDA, they actually specifically say this is for mild to moderate stage or moderate to severe stage. And because that's how we started to approve it. There's another small group of patients, very rare, they come from mutation. This is actually help us to learn Alzheimer's disease. They're not very common. Usually this is what we call a mutation cause the Alzheimer's disease. And if you ask the family history about 3 generations, first degrees, that's how I usually do. If it's genetic mutated one, you will have, because they dominate a mutation, means that 50% of the family members, they usually have symptoms. Because once you carry a gene, you have disease as early as in the early 20s to start to show symptoms. And there is a group of these folks have been studied at Washington University with a special programs. There are about more than 300 of them in the programs to study them. I personally have seen a few of these patients. The earliest one have been diagnosed about age 28, and those are folks, they usually will progress very fast. They usually become fatal, become very difficult to do anything, doesn't eat and waste in their bodies. And so the average lifespan down to about 50s. So these are actually very rare. That's why we truly call the mutations a familial type Alzheimer's disease. Now, the other part of genetic research, which have been going on more recent 20 years, the mutated gene, we did not find any new recently. What we found is called a risk gene. The risk gene is different part of gene influence Alzheimer's disease, not direct cause Alzheimer's disease. The first one discovered by Dr. Alan Ross is called ApoE phenotyping. And this is the one that actually opened the door that right now we have more than 20 of these risk genes. And these genes actually, they're all very good for some of our function, like ApoE432 is very crucial for lipid metabolisms. But what was known from the research is that if you discover that there are ApoE4 carrier, they're actually very efficient for lipid metabolism. But somehow, if Alzheimer's disease amyloid started, this gene carrier somehow will have hastened the change of amyloid so that they will have earlier onset of Alzheimer's presentations. So the study actually what it means is that if we all reach age 85, we will all have Alzheimer's disease change in the brain. If you carry ApoE4 gene, it will occur like 8 to 10 years earlier. But does not mean it will certainly cause Alzheimer's disease, because they are ApoE4 carrier, they never develop Alzheimer's disease, even under the autopsy. And majority of people carry ApoE3, they will have Alzheimer's disease when they're getting older. So in scientific world and practice world, we don't recommend, I personally don't check this for diagnostic use, because this is actually sometimes a little bit confusing. It's not a definitive testing, but we do use that for research, because that can be a little bit predictive. And more importantly is that the current treatment about amyloid immune therapies, ApoE4 carriers seems to carry a little more side effect. That's why we mostly use this for treatment option to choose. But this is not just only one. There are about a set of more than 20 of so-called risk gene we kind of found that can also influence the Alzheimer's disease in different way, either delay its onset or push the a little bit early onset. And we study them to find different treatment pathway. So this is how we use it in the research. And with the recent effort trying to see how much our diagnostic tool in a clinical setting, this is another study in recent 20 years, is the clinical diagnosis we made using the previous set of criteria. We often have false negative and false positive. And the most commonly is that sometimes you don't call it Alzheimer's disease, autopsy turns out is Alzheimer's disease. That's called a false negative. And sometimes you think it's Alzheimer's disease, when you have autopsy, it's not Alzheimer's disease. So that's what the differential diagnosis is trying to do. And these are the study actually kind of honestly collect all the cases from the Alzheimer's Center around the country and teach us there is a limitation of our clinical diagnosis. So these are really kind of affect us regarding treatment. This is actually fundamental affecting us is that how do you apply the treatment for Alzheimer's disease? And particularly the first step, you want a correct diagnosis. And then how do you treat them, even talk about primary prevention? This is the idea I've been talking about in the recent 20 years. Is that even possible? It's that because of our diagnostic tool become more advanced, then is it possible to diagnose or so-called prevent the Alzheimer's altogether? So this is actually an ideal approach we're trying to achieve in the future based on the research. What we can do is so-called secondary prevention is that if we can diagnose them sooner based on amyloid or tau, particular amyloid changes, maybe we can stop the disease, because this is really the first major player causing the change of the brain in Alzheimer's disease. So now we actually achieve this because we have more powerful tool to show the change in the brain based on the biomarkers, blood tests, spinal fluid tests, or even PET scan. And the treatment we originally have for 20 years, mostly for symptoms, these are actually based on FDA-approved medicine. We have been used for 20 years. It's still useful, but you have to use it in the right stage of the patients. So one of the tools I'm kind of not going to go into detail is developed over 20 years ago is using spinal fluid. It's actually testing the compounds, the protein actually coming down from the brain. We can actually check that in spinal fluid and measure. There is a protein called amyloid, 1 to 42. Another one is the tau, and the tau also can change, called phosphorate tau. They're reflecting in the brain cell changes. In a different rate, they will come down to the spinal fluid. It took us about more than 10 years to know what it means, and the numbers of that reflecting how the Alzheimer's change. In the research we have done, follow people over the years, just look at amyloid measurement. Once it changes, in 3 years, you can predictably know they gradually go into Alzheimer's disease. So this is a tool can help us to diagnose earlier, but it's not a very definitive in a way. So you can see that it actually takes about 2 or 3 years, and know it's more sure it changed. But in a clinical setting, you really cannot do the spinal tap every year for 3 years. So that's actually the real world problems. Another powerful tool is the PET scan, which is actually based on the tracer. Everybody knows the PET scan have been used for cancer, and there's a tracer actually will show the sugar metabolisms of body, and that can help us detect the cancer because cancer cells use the sugar. But in the brain, we have studied that the brain cell use a lot of sugars. But what we see is not how they use the sugar. Is look at the brain, they don't use sugar. So that's kind of give us a pattern. Okay, the certain part of the brain, the memory part of the brain doesn't use sugar. Maybe that's Alzheimer's disease. But this actually proposal with a conventional sugar-based called FDG PET scan, it was actually 90 to 2000, 99 to 2000. FDA does not kind of saying that there's indications, so Medicare, Medicaid doesn't pay for it. So by research, they actually still use the FDG PET scan. But it's not specific. It's actually kind of reflecting the activity of the brain. In the recent 10 years, we found the compound they can label abnormal protein build up is abnormal form of amyloid, and that's a really powerful tool. And was actually approved, the tracer 2012, 2015. Now we have 3 different tracers FDA approved can use for this diagnosis. But it's also Medicare, Medicare doesn't want to pay for this because they don't bring in any new treatment. So, and this is the tool we actually use for developing new treatment now. We also achieved that we can also see the tau changes now. FDA approved the tau in a limited use for research about a year ago. So now we can actually see the brain changes before patient die. And we also follow people in the communities. There's a large aging community study run by Harvard Aging Studies, and in Boston there's a Mayo Clinic Aging Study. and with the other agent study, we can see the change of amyloid and tau even start to change when the people don't have symptoms. And this really kind of expanded our field about Alzheimer's disease. We can actually see the change in the brain even before they create any problem in the brain. And so this opened up the spectrums of Alzheimer's disease. Initially, let me go and show you the next one. So initially what we're dealing with when there are very obvious symptoms called dementia symptoms. And that's down to the condition that brain losing brain cell, a very obvious symptom we call dementia. And when we use the treatment, they really don't change that much. We actually change the course, make it not decline that fast as a goal of treatment, called a treatment effect, okay? And we really want to move earlier diagnosis so that we can make a more effective treatment before brain losing brain cells. Because once the brain losing brain cell, you cannot replace them. People are wish that we can have a treatment can restore the function, restore the brain cell. It's very wishful thinking, but in reality, we cannot reach that. So if we are hoping the treatment for Alzheimer's disease can restore the cognitive functions, restore the brain changes, we cannot reach that. So that's not a realistic goal of treatment. The realistic goal of treatment is to alter the course of disease. They're not getting worse that quickly, and stop it or alter in as early as you can. So if we can treatment in a more early stage, even without symptom, can we make a big difference? So this is really the research what we're going on at Rowan Hospital and our colleagues around the country trying to do. It's actually difficult to do because the study for cancer, they study about 6 months, no more than a year. For Alzheimer's disease, we have to study 2 or 4 years. So this has actually become more time-consuming and more expensive. So this has really come down to recent 10 years. We have this idea about Alzheimer's disease is not a snapshot of one condition at one time. It's become a spectrum. And if you can diagnose early, we actually follow people as long as 15 years or even 20 years. So this is a lot of time to provide a care. And it's very different from 30 years ago. 30 years ago in dementia, Alzheimer's disease, people actually from diagnosis to death less than 3 years. Now you can have diagnosis at least 7, 8 years if you're healthy, or even 10 years. I recently have one of my own patient actually have 15 years of story from the diagnosis I first made until he passed away. So this is the care enormously actually you really want to provide for the diagnosis of disease. The bottom line is really when can you make diagnosis, and at different stage what their needs and how to provide the care. It's really have to be tailored based on the staging. So we don't have a disease treatment to stop the disease, but this is what we're trying to achieve with some of the success with the recent research in immunotherapy, but because of controversy, I'm not going to go for too much detail here. So this is actually the diagnostic and treatment principle. This is what I preach, how I practice in my clinics. It's actually go down this flow to really to confirm the Alzheimer's disease, and they have different stages, mild cognitive impairment range, mild to moderate range of dementia, Alzheimer's disease, moderate severe range of Alzheimer's disease, because their needs are very different. So the more you can understand patient, their different stage, and the more you can predict how their needs will be and what will be a proper treatment will be. So this is actually, a lot of people actually may not pay attention to these different stages and the importance of that, particularly affecting the family members and the patient themselves and also in society. So I'm going to change the gear to the other dementia disorder. Does not mean I'm leaving Alzheimer's disease. Actually, these are conditions actually often mix or mimicking Alzheimer's disease. A lot of people are trying to reach a single diagnosis. Actually, what we learned from autopsy, a lot of these conditions actually either mix with Alzheimer's disease or mimicking Alzheimer's disease, and we don't have very good tool to diagnose them sometimes, okay? So some people, they come to my clinic, they will say, I must have this. But sometimes it doesn't. It's actually more complicated than that. One of those, the most common form is the vascular dementia. There's a new term called vascular cognitive impairment and dementia. It's acknowledged that vascular events, either from blockage of artery causing so-called ischemic stroke, or from the bleeding of the brain, they causing damage of the brain, depends on different location of the brain. They can have impact on cognitive functions in different degree. Some of the stroke, they're small enough, people compensate, recover. Some of the stroke causing enough damage to the brain, they cannot recover. And there are certain degrees of the cognitive impairment, either described or not described. And if you have 2 or 3 come together and impair their cognitive functions, for example, they cannot talk as what they can do, particularly if they're a reporter. They cannot write like what they used to. They have trouble to think. And these are the impact on the daily life based on the damage to the brain. So if you cannot find anything else, and that's truly caused by stroke, and that's called the vascular dementia is, but the pure vascular dementia in older folks is actually rare. Because when we look at the brain, these are all different kind of vascular change in the brain can cause impact on our cognitive functions. A British pathologist actually make this picture that all these presentation damage the brain can have a certain impact on the cognitive functions. And one of them actually they often mix with Alzheimer's disease. And so people have Alzheimer's disease, can have a stroke. Some people had a stroke, then found they also have Alzheimer's disease. And when they already diagnosed Alzheimer's disease, in a way, some Alzheimer's disease change can also trigger the stroke-related symptoms. So they become hand-to-hand to getting worse. So sometimes in my clinic, I'll tell the patient which one we want to treat when they're getting worse. I need to find out the driving force of getting worse, is that from stroke or from Alzheimer's disease? Sometimes very difficult to tell. So the differential diagnosis is really trying to understand what really caused the change. You know, sometimes it's come from Alzheimer's disease, sometimes from the vascular events. So these are not single, separate identity. These two conditions often together. So there is a diagnosis I usually make. It's called mixed type dementia, which is mixed with Alzheimer's disease and the vascular cognitive conditions. So these are all the different types you can see. The next condition also mixed with Alzheimer's disease is Parkinson's disease. Actually, Parkinson's disease is the second most common neurodegenerative disorder in the senior, particularly older than 60 above. Because they actually start around the same time. Parkinson's disease used to be considered more treatable because they have very effective treatment to change or improve their motor functions. But Parkinson's disease patients, they live longer. And we found that the change inside the brain that causes Alzheimer's disease is because of a protein change and causing a particular protein inclusion body called a Lewy body. And that exists in the certain cells. Initially, it was just very simple-minded. It's only in that cells affecting chemistry, dopamine. But with a more extended brain exam, it actually doesn't exist just there. It actually exists, was spread entire brain. So Alzheimer's disease and Parkinson's disease, actually we learn each other because Parkinson's disease, when we examine the brain, how to spread and go over the whole brain, it looks like Alzheimer's changed over the years. So in the past 20 years, the textbook about Parkinson's completely changed. What the description is that Parkinson's disease actually evolving will involve entire brain and then eventually causing dementia syndromes. And this spectrum also changed in the other way is that some patients, they look like Parkinson's disease. They don't respond to typical treatment in the beginning a year or two. They become very difficult to treat. They have a lot of hallucinations. They have a lot of behavioral changes. They have a lot of a change in their sleep and all that. So with the autopsy, we found that this is not like typical Alzheimer's disease, Parkinson's disease, actually. That's why we call it dementia with Lewy bodies. And this is a very awkward term because people are actually difficult to understand that. This is actually evolving from the spectrums of what we know about this abnormal so-called Lewy body you can see in particular cells now spreading to different part of the brain. So they can create different syndrome when the part of the brain particularly affecting or develop is called Lewy bodies. And we really don't have a way to show you what a Lewy body is unless we look at it under the microscope. And we don't have a diagnostic tool to show it with the imaging. So dementia Lewy body become very difficult diagnosis to make. Sometimes people made it to explain difficult diagnosed patients. Sometimes they don't want to make it because this diagnosis have no treatment. The most recently, because Robin Williams has been diagnosed and his wife has been an advocate of these conditions. But in terms of science, this is actually has been quite behind about research. And on the other hand, we found that if you look at the brain in Lewy body dementia or Parkinson's disease dementia, particularly in 70 years old and older, the Alzheimer's disease also exists in the brain. So this is not a pure Lewy body dementia. Actually, in a certain degrees, we can also see Alzheimer's disease mix and create a change in the brain. So this is a much complicated situation. So you really cannot single out say, this is really the Lewy body dementia, nothing else, okay? Wait a minute until you see the brain. Because we have to be cautious that the patient's presentation is determined by which part of the brain change, they have different symptoms. And then which the pathology, either Lewy body pathology or Alzheimer's pathology, is a driver to cause the cell loss. So they will present different symptoms. So in terms of treatment, even though we don't have a fundamental treatment to cure or treat this condition, but we borrow the treatment from Alzheimer's disease to try to help with the symptom, manage the care. So this is a much complicated condition to make diagnose, to manage for the caregivers, and there's a particular society for this, is to address these complexities of the care and conditions. The bottom line is that they often combine with Alzheimer's disease, and it's just very difficult to tell sometimes. The last one is a more relatively rare type of dementia disorder, even more mysterious, because the presentation of the condition usually it's more unusual way of presentation. They also mimicking Alzheimer's disease in somehow. And this is the condition I described many decades ago. We only have learned this more better with more autopsy we learned from the patient's brain. And we call it frontotemporal lobar degeneration. In a simple way, in English, very simple. It's the front part of the brain called frontal lobe. The brain on the side close to the ear called temporal lobe. These two are the part of the brain, they carry specific function. And these patients, in the old days, in autopsy, you just see that the frontal part of the brain and the temporal part of the brain, they're losing brain cells, shrinking most. That's why I call frontotemporal degeneration. Nowadays, we have a CT scan, we have MRI. That's why you see that for outstandingly, they have these two parts of the brain, frontal and temporal lobe, losing brain cell more. And the most interesting is they can start with just one side, either start with the right side or start with the left side. So the symptom become even more interesting because if you're on the right side, it's more behavioral. On the left side, it's more lingual language. So patients usually present with language problems and often get misdiagnosed with something else. So fortunately, this is a rare diagnostic entities, but sometimes this has also come to my clinics for more expert opinions. And we classify them based on the symptoms. Also, the symptoms are based on which part of the brain has changed. If you have changed more in front part of the brain, it's affecting your decision-making, your organization skills, decide what to do, what not to do, emotions somehow in a way. But if you're affecting the language part of the brain, you impair your language skills. A lot of people have this disease actually was a very good speaker and writers. and very impaired their ability of language skill. That's what they cherish very well. So it's very devastating for those folks. In fact, one of the neurology chairman actually started with the disease. He cannot talk anymore. So these are very devastating in a way. So in the past 10 years, we have a society, International Society of Frontotemporal Dementia. We often meet every 2 years. And we learn a lot from the autopsy of these patients around the world, not just in the United States. In a group of us, a meeting usually less than 500 around the world. There's not many of us, okay? And we originally thought it's just one protein change. It turned out there are different mutations can cause these, and most surprisingly, atypical presentation of Alzheimer's disease can also create these syndromes, which is actually very surprising. People believe that this is not caused by Alzheimer's disease, but sometimes when we autopsy, we found actually it's the pure Alzheimer's disease, just target a different part of the brain. That's why they create a syndrome. And there are about 3 or 4 different protein changes in cells can also cause these syndrome, but if you look at the brain, they change in different ways. So it's very difficult to diagnose them, what really changed inside the brain. We can only base on how their symptoms evolve and how the brain losing brain cells predict how they are affecting in their real world. But in terms of what causing the brain changes, it's more complicated because it can be Alzheimer's disease or can be other 3 or 4 different proteins. And we don't have clear-cut testing for it. So it becomes very mysterious. And the care is most important, is keep them safe and make sure they got what they need for their safeties and daily function. And this is a much rare form of dementia, often occurring in the younger patients in the 50s and early 60s. So they're more difficult to reach the resources of care. So often the so-called young onset dementia, they actually usually belong to this group. It's about 10% of the dementia populations. Now, the last one I want to talk about is actually, this is a more a complicated one. Having said all that, with a differential diagnosis of dementia, I can tell you that when they're getting worse, they all require the same amount of care, no matter whether the dementia caused by Alzheimer's disease or caused by vascular dementia or caused by Lewy body dementia or frontotemporal dementia. When they're getting worse, these are the patients, they will need the same amount of care. In terms of different diagnosis, become not very important because they will need manage the behavior. They will talk about where they can provide care still at home with the manpowers they have in the family. And safety is most crucial, and how to talk about the driving and the finances, how to secure finance to provide care for a longer period of time, and how to decide when is a facility care will be needed, and even talk about end of life cares and hospice. These are all the conversations I have individually with my patient, my clinics. My point is, my experience practiced 5 different states in 20 years, and there's no which one is the best, because everybody wants to know what's the best for my wife, what's the best for my husband, what's the best for my mom, what's the best for my brothers or fathers. There is no what is the best. It's actually to understand the patient is most important. My expertise try to understand the patient, what is the impairment, what they can do, what their condition is, mild stage, moderate stage, severe stage, what their more outstanding problem, so then you can provide the care at that stage. And then you look into your situations. Some of my patients want to move to close to one brothers or one kids, or close to which facilities. Chicago had different provided facility compared to Texas. And California the same way. And if you move to New York, there's all, there's no which one is the best. I have a patient when I was in California, his daughter actually lived in New York, and his wife was whether he taken care of at the Southern California or New York is better. There's no which one is better because in the end, he's going to stay in the house. He's not going to enjoy the nice sunny Southern California. You know, in Chicago, there's a high-rise care for patients. They're actually much more well prepared compared to folks they live in Florida. I have a patient in Chicago, they moved their mom from Florida back to Chicago because Chicago has more care system in a way. So it's very difficult to decide, and there's no what is the best. You know, people are searching for internet and as expert. I always kind of advise them is actually look into the needs of patients, and then what their current condition is, and talk to physicians and expert and put it all together. And I usually advise them to, you know, mark every test they need to do throughout 24 hours, and what the ability they can do self-initiated or need to remind or need to be assist. And that will translate into how much hours the patient needs to be helped. And then you will know what manpower you will need. And I have patient family members, they try every kind and they change. One of my patients in Texas, he has 8 different children. The oldest daughter is a commander's, assign a brother and sister what you do. So initially she would take care of the father because mother died, she become the head of the family. But then she burned out and she assigned a brother and sister, 7 of them rotate, each one 1 month. They did that for about a year, everybody burned out. And then they, move into a facility and they will visit him every day. You know, she will assign, today is my duty to visit my father, tomorrow my brother visit. You know, it really depends on stage of the care. So you try to make decision in a way. And so that's what the constant review is very important. I think that's it. Any questions? Yeah. Yes.
So my mom has a number of medical issues that require her to be on just a myriad of medications,
Yeah.
including which is chronic pancreatitis. So she's been long-term on narcotics. I'm wondering, what's your opinion? I've done some of my own research, but what's your opinion as far as those types of medications and increasing risk factor for Alzheimer's and dementia?
Yeah, it's actually the number one diagnosis is very important to confirm the diagnosis, and then among different, in principle, the medical conditions, what combine. And then the, like my colleague, geriatric medicine, they're very specialized and look into all different conditions and to sort out what's a priority. Otherwise, polypharmacy become an issue. So diagnosis is most important to confirm diagnosis, and diagnosis of what caused dementia, also other medical conditions, whether congestive heart failure or kidney problems. And these all need to take into consideration to find out what would be a balanced solution for the treatment.
Have you noticed the correlation between people being on these types of medications and being more prone to suffering from Alzheimer's or dementia down the line?
Depends on complexity. So the geriatric medicine doctor, they are more specialized way into these complexities. Yeah. All right. Yes.
So the last meeting we were in, they suggested we come here to get this question answered. So if you have someone that needs possibly the Alzheimer's treatment and diagnosis, what are some of the steps you think would be best to follow? Can you go to a clinic like yours and that would have everything? Do you go to a primary care physician first? Do you go to a neurologist? Do you go to a psychiatrist who has the questions? I mean, what is your basic?
Yeah, actually, yes, I got your understanding. Yeah. As I said, I practice 5 different states in different settings.
Yeah.
in the real, when I come back here, the same way is, actually primary care doctor is the key. They're actually very good at, they know the patients. We don't have everything. Even we like to see whether we have, because comprehensive care for dementia patients is very complicated, even in the research, NIH-funded research, and if you go to Boston, either Harvard or Boston University, where I was trained, and also do research over there, they don't have comprehensive care. Nobody have comprehensive care in the world or countries, or the United States, every state. What they provide is the basic care from primary care doctor is essential. So that's why we advise primary care doctor refer to us, because primary care doctors, either internists or family medicine, they're very good at the general conditions, and that's a fundamental to do. And based on the referral I have seen, they already make diagnosis of Alzheimer's disease. They actually they already can make diagnosis of Alzheimer's disease in a very accurate way. It's just they may not know to answer questions and how to address specific questions for patients with different symptoms. So then they need to refer to us for second opinion. The neurologist and psychiatrist is really based on specific symptoms. Let's say you have Parkinson's symptoms, you're seeking for treatment, you send for neurologist. And if you have more outstanding hallucination, behavioral problem, that's what the psychiatrist send to. But the care need to centralize, go to the primary care doctors. The research is for advancing our understanding, provide new treatment. That's really a different aspect now. But the diagnosis made and the care plan need to organize and with the primary care doctors. Yeah. Okay. And yes.
Are there any clinical studies or research studies going on right now in the States for someone that's been diagnosed with Alzheimer's, Lewy body,
Right.
moderate stage?
Right. You mean regarding Lewy body or
Are there any clinical studies right now going on that?
Yeah, Alzheimer's disease is the only one right now has most funding and study. Lewy body dementia has less funding for research. The research level is very different. So in Lewy body dementia, they even started, right now they're at a stage of how to make diagnosis correctly. So the research for Lewy body is not more individualized instead of national-wise collision. Like Alzheimer's disease, we are belonging to a national-wise collisions because that's actually more far advanced about treatment. But
Is there a listing of what these research projects might be?
I think the Lewy body dementia society tried to make a list of that, but it's not really, it's not as strong collision like Alzheimer's Center. But most of people, especially Alzheimer's disease like me, we also see Lewy body dementia. But the colleague we know, it's difficult to carry out the research for Lewy body dementia right now because funding source and then collection of cases is not, you have to have a special registration for the case, and so that you can form a meaningful research for even diagnosis or treatment. So their research about Lewy body, it's mostly for individual clinicians or scientists, but it's more like individual efforts. There's no collisions of a study like for Alzheimer's disease. Yeah. Yes.
Doctor, to that question, the Alzheimer's Association Rhode Island chapter can get anybody who wants it a list of all the clinical trials that are taking place in Rhode Island today. If you contact our office, we'll get you that list.
Yeah, but she's talking about Lewy body disease.
Right.
Yeah, yeah, yeah. Any other questions? Yes.
What kind of emphasis do you put on lifestyle modifications once you diagnose a client?
Yes.
Once you diagnose them, how much emphasis of guidance do you provide?
Yeah, again, to answer that question, the most important is certainly you diagnose Alzheimer's disease, first step. Second is you need to know what stage. If they're very early stage or mild stage or moderate stage, so then they have different ability they can do. So if they're very, very early stage, they almost like normal, they can engage with activities. But if it's in the moderate severe state, their capacity can do those activities become limited. So the lifestyle is mostly the same as we follow the one actually studied for heart disease. So the exercise and also particular intellectual activities, it's way to choose what they like to do. So engage intellectual activities. Actually, I usually ask them, what do you usually do before? Do you read? Do you listen to music? Do you watch movie or follow particular sport? Spend a amount of time with so-called intellectual activity style. Lifestyle is like, it's actually scheduled their daily activities. If they can self-initiate it, like in the very early stage, 8 to 10 doodles, 10 to 12 doodles, you can kind of follow your own schedule. But if you are in a moderate to severe stage, you need somebody kind of help them with this kind of activities. So mostly have three kind of activities. One is physical exercise, as simple as take a walk outside, or expose to sun with nice sunny days and even in the yard. And the second one is the social activities, interact with family members. And the third one is intellectual activities. So you kind of mark them, let's say 8 to 10 you do this, 10 to 12 do this, 1 to 3 do this. And if they cannot self-initiate, that's where the caregiver will kind of design to enforce to do that. And also based on certain of the patients, how engaged they can be. Let's say in the morning to 8 to 10, maybe they better just chatting or reading newspaper, depends on their preference. I think the bottom line is that what stage they're in. Even they're in a nursing home, memory care unit, I think they also arrange the activity like this. So they kind of fit with every stage, but it's really to see what kind of activity they can participate. Yeah.
But it's part of your discussion with the
Yes,
parents that you
yes,
get.
every one of
These
them.
are like things that they can do to promote.
Yes, correct. Yeah. I actually review with them next visit with a follow-up, and family member report to me how they achieve. Enforce, and I had coached them and to encourage them. Yeah, because if you keep the activity during the day and night has a difference. It will help them to sleep at night. So otherwise, they'll sit there, doesn't do anything. Particularly more moderate severe state, they don't initiate. So you need to coach them. But the more mild state, they can do by themselves. So they just need a guidance to do what they need to do. And, yes?
With a person at the end stage of Alzheimer's, is the quality of their life if they had to go into a long-term care facility, is that worse than trying to keep them home, or is it more activity in the nursing home?
Right. So I kind of answer that question. It's also different. So this is what I usually tell patients. There's no which one is best. So I have patients, they actually, in the end, still at home. Depends on how you can provide. Facility the same way, because you really need to look at the patients and the loved one, what they need. And then based on what they need, then the question, can you provide? Are you providing at home or are you providing in the facility? That's really the question whether,
If they were safe at home,
right.
it's a lot of the socialization. I don't know whether it would be better in a long-term care facility or being home and just sitting all night.
Right. So depends on how many people you can bring into the house. Like Mr. Reagan, he has 24-hour care at the house, right? And I have patient family, they hire 3 ships or 4 ships to accompany the patients. The husband watch out for the wife, and they're from 8 to 10 is the daughters, but there is another one come the ship to go out, and keep them awake during the day and nighttime sleep. It's really is it really how much you can arrange. I think the care you provide in nursing home and the house is the same. It's who provided, and what is the need they need, the basic personal hygienes, the eatings, and activity. Those are very basic. Either your facilities or in the home, they should be the same. It's just the manpower in the house, it's difficult to provide. But if you can provide, it can be done that way. The social contact in a very severe advanced state, patient doesn't recognize family members, social activity limited, is not because they don't want it. It's more like they don't have ability to do too much interactions. Yeah. So limited way, take out to look at the flowers and see person he recognize in a way. It's very limited social contact because they cannot interact anymore. Yeah. So I just kind of repeat what I said. Is we have to see what the patient need, and then you can see what situation is you can offer or provide. Yeah. Any other questions? Yeah. Yeah. Okay. Yeah. Okay.
Thank you, everyone. If you need CEUs, make sure that you've signed up with Jenny. There is a boxed lunch in the rotunda, and we are encouraging you to share your lunch in the Plaza Ballroom. There's going to be a special presentation. So thank you all. Oh, I'm sorry, Grand Ballroom, the big one.